Hello friends, I am Dr Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. So in this video, I'll be just going through a routine case. So do you watch your videos again that you have done a routine surgery, but just if you watch them again, sometimes you find that you have done something right or a few things wrong, and it will always help you in improving your surgery further. So this CCC is being done under the cover of Hylucoat, which is a heavy dispersive OVD, and using cystosome and the main incision. So as you could see, I was just going around that central Purkinje image, trying to make it as centered and as circular as possible. There goes the hydrodissection wave, and it's very important to little bit decompress the anterior chamber. You can see those bubbles in the AC, and those are little bit annoying. So it's best to avoid those bubbles when you are injecting viscoelastic. Now once the nucleus rotation is done, I am preparing for the phaco and just thinking what kind of technique I should use. Now this is a cortical soft cataract. There goes the air bubble. It comes in because you are not primed. So you have to start the irrigation little bit earlier so you don't get the air bubble when you insert the phaco probe inside the anterior chamber. And now because this is a cortical soft cataract, the thing in my mind is I should not create a bowl in this particular case, because that's the commonest thing to happen when we deal with cortical soft cataract. So there goes a deep trench. So I have decided to do a trench divide, and for that a deep trench is needed. So just watch that I am going for the deeper trench and then dividing. Now before I take out the first piece, I have to make sure that it's free and it's nice. So it's free from the other pieces, little bit attachment in the center, but that doesn't matter. I approach the piece at the anterior edge so it tumbles in the center. Now once I remove the second piece, the thing in my mind, or I start observing the posterior capsule here. Okay, if there are any fluctuations or not. There are no fluctuations so far here. So I know that the fluidics are working really well here, and I don't have to worry about posterior capsule coming up while taking out the last piece. Just you can see the anterior chamber is very well stable till the end. Now the assistant is shifting to coaxial IA. That's the common thing that I use. So I'm just observing for any other thing which are there, and also this is time to relax your eyes a bit because you're constantly focusing through the microscope. Just look around and relax your eyes. That helps during the surgery. Otherwise your eyes get tired when you're doing 20-30 cases in a day. So the time between the shift from phaco to coaxial IA, while the assistant is doing that, it's time to relax. Cortex aspiration is smooth. I'm just polishing the posterior capsule for a little bit of those fibers which were there. I don't really polish the anterior capsule because I don't think it is useful. It has been proven in studies as well that it has no role in prevention of posterior capsular opacification. I have used methyl cellulose here for IOL insertion. This is a dispersive OVD. So the issue with that is that though it forms the chamber nicely, removal of it takes time. So nowadays I have shifted from methyl cellulose to 1% hyaluronate for the IOL insertion. Now this is a single piece hydrophobic IOL. Just watch how I carefully put. This is an open cartridge, so I have to put it in the groove properly and close it and make sure that haptics are not get strangled in that cartridge. So once I see the free movement of the IOL, it's ready. Now I am using a 2.8 incision here, and the cartridge is meant for that. And for this you have to give counter traction with the Sinski in the left hand. You can see here the cartridge is trying to come out of the incision, and that is the place where you have to push it further and give counter traction with your Sinski. You can see those fine white particles there. These are the lubricating material which are there in some of the cartridges that we use. These are totally inert and they get aspirated very quickly, and even if little bit is left, it will get absorbed. So no issues with this. But of course there are better cartridges which may not have this lubricating material. We hope that most of the companies will shift to these newer cartridges now. So as I mentioned, this disperse UVD which is inside, so I have to make sure that I remove it all. So always take your time for removing the OVD. Watch how I go over the anterior surface of the lens as well, because these OVD, they tend to get stuck with hydrophobic material. So it's better to just clean them off the surface of the IOL as well. That gives better tackiness for the surface of these hydrophobic IOLs, so they stick to the posterior capsule and you will have less PCO later. Removing all the OVD, try to remove it all, though I know that with methyl cellulose or any dispersive OVD, a little bit will always stay back, and that's the reason I shifted to hyaluronate for IOL insertion recently. But still, even with methyl cellulose, if you are thorough, you will have very minimal reaction and patients are quite comfortable. That's the end of the procedure, just hydrating the incision. Always hydrate the outer half of the incision, never go inside or inner half, can cause descent detachment. Nicely form anterior chamber. So always watch your routine cases also. Again, sometimes I feel that when I watch my surgery, which I have done 1 year back, I have made few changes over even last 1 year. So always when you watch your surgeries which are otherwise uneventful, it will help you improve few things. Thank you so much.